Hello, everybody. It's Dr. Becker. Let's get started on week 12. This week's competency here is guidance and coaching. And I think that guidance and coaching is one of the things that I don't know that I clearly identified with as much at the start of my APRN practice, but I love that it's more promoted now as something that we really should be competent in and more aware of. It is a distinct competency and really is at the heart of nursing because we are trying to be engaged and be effective in engaging the patients to have healthier lives and to be leading their own change of their own lives. And that's really pretty awesome. It's integrated into nearly every competency, and it really helps engaging others effectively to build rapport through deep listening and building of our authentic therapeutic exchanges with our patients. APRNs are most likely to use both guidance and coaching as an integrated model to help patients gather the motivation necessary to engage in change of themselves. The why of guidance and coaching is to engage patients in their own care and to prevent or effectively manage their chronic illnesses or disease. And really, it's to help keep the patients as functional as they possibly can be throughout their lives. So nursing, because we look at people holistically, we are more prone to being effective at guidance and coaching. There are many reasons why people are becoming more engaged in their own healthcare these days, and mainly it's because of the internet, right? This is the Dr. Google era that we are in. So the reading talks about the ease of information access through the internet, the shifting costs of care to consumers, and the heightened awareness of healthy behaviors leading to longer health spans helps create independence and functionality amongst patients. And patients' experience surveys focus on how patients feel about the care they receive. And for care institutions, payment add-ons or decrements depends on those patient experience results. Guiding and coaching patients requires patient activation and empowerment by placing the responsibility of the pursuit of health where it rightly belongs, which is with the patient. It provides patients with this critical information about quality, enhances patient-centered care through client-monitored medical homes or finance new models of care. So what they're talking about in that statement is that health systems are continuing to design care that engages patients in their treatment, develops their abilities to manage their health, and lowers their modifiable risks. It helps the patient learn to express their concerns and preferences regarding treatments and empowers them to ask questions about treatments and really promotes this patient-provider partnership with shared decision making. The current model of care that we have in the United States does not work for lifestyle-related diseases. This is what the reading was talking about. Heart disease, cancer, respiratory illness, and diabetes account for 71% of deaths worldwide. It's from the World Health Organization. So we know that those kind of diseases are costly and they're the lead driver of healthcare costs that are amenable to prevention, right? Again, we're talking heart disease, cancer, respiratory illness, and diabetes. So essentially also smoking and an unhealthy diet. So these diseases, though, are caused by the four main risk factors, which are tobacco use, poor diet, alcohol use, and physical inactivity, which this is America, right? We are all, when we look at Americans versus other countries, we are inactive and overweight, and we do things like have a really bad diet, and we use alcohol, and we smoke or use tobacco. And so if you think about that, well, then it's no wonder why people have heart disease, cancer, COPD, and diabetes, right? Those are all diseases that are markedly worsened by the lifestyle choices that patients make. So helping patients change their behaviors will decrease suffering, early mortality, and disability. In your reading, it said the startling statistic that represents opportunity for behavior change is the number of people who are obese. Okay, so the number of people who are obese tripled between 1975 and 2016, with over 340 million children and adolescents aged 5 to 19 who are overweight or obese as of 2016. Okay, In 2019, it was estimated that 38.2 million children under the age of 5, you guys, were overweight or obese, according to the World Health Organization. So again, we know that the burden of these lifestyle decisions are going to directly impact their care. So what we do through guidance and coaching then is to be able to say, let's form this therapeutic partnership with our patients and empower them and educate them and guide them and coach them to understand how their lifestyle choices can very much negatively or positively impact their overall health. And all of us know that these lifestyle factors, these behaviors can be modified to lessen the risk of chronic illness. People can reduce their chances of getting the chronic disease or improve their health and their quality of life if they even already have the disease by making healthier choices. Okay. A study from 2016 showed that only 6.3% of U.S. adults engaged in all 5 key health behaviors that can reduce the risk of chronic diseases. Those included avoiding alcohol, exercising regularly, getting enough sleep, maintaining a healthy body weight, and not smoking. So there's only 6.3% of adults that will manage to do all 5. That is dismal, right? So if we are truly going to help our patient to empower them to be as healthy as they can, and only 6.3% of them are going to do those 5 things that we know can do that, we are failing them miserably. So when you look at American healthcare overall at this through this lens of how unhealthy we are as a people, it clearly becomes evident why being guidance and coaching with our patients for sure is necessary if we're really going to help care for them. So let's define a little bit what the difference is. When we talk about guidance, again, it's a really broad term, and it means the provision of help, instruction, or assistance. And again, there are several forms. So the distinguishing feature of guidance compared with coaching, right, is that guidance requires the provision of advice or education, whereas coaching is an inquiry and excavation of answers from a person. So to guide is to advise or show the way. So guidance can be considered the act of providing this expert counsel by leading or directing or advising. And so to guide also means to assist a person to travel through or to reach a destination. Guidance is best used in situations when a person has a perceived knowledge deficit in an area for which you as an APRN can fill that void with your knowledge. When providing the guidance, the APRN is servicing as a knowledge expert or the source for the patient. Guidance can include laying out, simplifying, or integrating the options for a patient to make a healthcare decision. But it is imperative that you as an APRN determine the patient's level of knowledge before you launch into guidance, right? So that makes sense because you don't want to be patronizing. You don't want to waste their time telling them the things that they already know or make them feel like you're patronizing them. So asking patients what they know about their condition is an important skill to respectfully build upon that. And then as an APRN, you can guide more powerfully and effectively. Okay. So different forms of guidance. Again, we're talking about giving expert counsel, advice, or education. We're advising. Anticipatory guidance is aimed at helping patients know what to expect. Anticipating common problems or symptoms and what to do about them can go a long way in reducing unnecessary care, promoting self-efficacy, and reducing their anxiety. It informs the patient, like after an injury or diagnosis, about an expected health process that's likely to occur in relation to injury or diagnosis, right? It's something as simple as, the swelling's going to worsen, the bruise is going to change a whole bunch of different colors. It could take weeks for that bruising and that swelling to go away. That's okay. That's anticipated. That can go a long way, whereas if you never shared that with them, they would maybe get anxious or worried about that. Patient education is patient empowerment by teaching the patients about their illness, their condition, and then guiding them to be more involved in the decisions about your care and treatment options. So the HWO defines patient education more broadly as any combination of learning experiences designed to help individuals and communities improve their health by increasing their knowledge or influencing their attitudes. So the goal of patient education then is to produce change and promote self-care. We as healthcare in America for centuries, healthcare meaning doctors, nurses, what have you, for many over 100 years now, we've held on to this idea, and in the book they refer to it as a myth, that if the patient is provided with the right information, the patient will see the wisdom of making change in their life to be healthier and simply follow the directions, which is kind of funny. Learning experience is designed to help patients improve health by increasing knowledge or influencing attitudes. So then we can go into mentoring. Mentoring is a relational process where one person with more knowledge in a certain area provides guidance to the other, typically a long-term relationship spanning careers or lifetimes, and mentors provide advice and support to help mentees attain their goals, and is usually mutually beneficial to both parties. Mentoring in this form, to me, of the APRN is more of what we do within nursing itself and not necessarily our patient interface. Counseling is the professional relationship that empowers diverse individuals and groups to accomplish mental health, wellness, education, career goals. It's generally focused on a psychosocial, social, or performance issue in a problem-based approach. If we get into then coaching, this is again a broad term, and it's referred to in your book as a broad umbrella term that then encompasses different approaches, philosophies, techniques, and disciplines. Coaching is defined by the International Coaching Federation, the ICF, as partnering with clients in a thought-provoking and creative process that inspires them to maximize their professional and personal potential. For APRNs, this definition also extends into a health potential. The ICF identified 4 main domains of the coaching responsibility which could apply to the APRN practice, and those are discover, clarify, and align with what the client wants to achieve. Encourage self-discovery, elicit client-generated solutions and strategies, and hold the client responsible and accountable. I really like that one because it really talks about coaching is one of those things where you do hold the person accountable, right? With positivity and with guidance and coaching, we are trying to strive to empower them in those things, but it's very much like what a coach is in athletics or a personal trainer. You know, if you show up to your personal trainer session and they say, your assignment was to get, to walk 4 miles over the weekend, and you show up with your pedometer and you've walked nothing, they're going to hold you accountable. They're going to say, okay, you decided to do something outside of the plan we arranged on, so now we're not at the same spot we were hoping to be. We need to regroup and redo it. And if they cry about that, or if you whine about that, they're going to say, you chose this, right? That is kind of the idea of coaching, even in healthcare. The really important part about coaching, too, in terms of healthcare specifically, is that you really have to form the relationship and your goals based on what the individual patient identifies as their goal. So again, if you have a patient that is not going to have the same goal that you have for them, or you have different goals than what they have, it's not going to go well. An example of this I can relate to in my personal career was in cardiology clinic. We were trying to get it so that I would be doing hypertension clinics. And so these difficult to control hypertensive patients, they would have them come over to like my clinic, and we would do a more intensive workup to really do all the things to say, why is it that you have this difficult to control hypertension? Order all the tests, do everything. And I would see people about every 2 weeks. And the idea was that there would be a lot of guidance and coaching, essentially, and saying, look, we have to address these lifestyle things that you have because your hypertension is going to kill you. Like, we got to do this. And I remember in one instance, I had a lady that really had identifiable factors that I knew if you could just work with us a little bit and make healthier lifestyle choices, we could get your hypertension under control. And she really felt miserable with her hypertension. She had these chronic headaches and just felt tired and drowsy a lot of the time. And she'd gone through a total workup and everything else was pretty good. And I was really excited because I thought if I could teach her and help guide her through some of these things, we could get her to a much better place. And I very kind of did the opposite of what a good coach should do. And I didn't listen as well as to what her goals was. And I was going in it like, hey, I think if we do these things, I can get you off of these 5 medications we're using right now and maybe get you to 1 or 2, probably 2, all excited. And I went through this long rigmarole about lifestyle changes and all this stuff. And okay, sent her out the door. And in 2 weeks, she comes back and she had actually gained weight, still smoking, all of the things. And I'm like, what did you do? We talked about this. And she finally looked at me and she goes, well, I didn't have the heart to tell you because you were so excited. And I really care, or I'm really glad for your care. I'm very grateful that you were really invested in me. But honey, I'm not going to do any of those things. I just want my pills and to have my headache go away. So if you have to give me 7 pills, I'm okay with that. And I was like, oh, perfect. Never mind. That has stuck out with me since then because I thought, how did I miss that? And I was so excited about the clinic I was running and the things I was doing that I really missed that cue she was giving me, that she never really told me, yes, I agree, I want to do those things. So I just put that out there as a real life anecdote to kind of show that they need to buy into what you want to coach them on. Your goals and their goals have to be in alignment. And really my goals as a provider ultimately come second to what their goal is. Now I can try to guide them, right, and educate them to change their goal and try to get them to buy into it. But at the end of the day, what they are willing to do and not do is what's going to determine how I do what I do. There's considerable discussion within coaching as to how much advice giving should be offered. So because coaching is considered a partnership, the APRN must trust that the person has their own answers that are true and right for them. That's really a powerful line from your reading because, again, with working with patients to make changes different in that providers have specific health-related information that the patients need and want, but they also have to want it. Very important part. So different types of coaching. We've got motivational, integrative, and nursing on here. Motivational is a focused approach to explore and ignite motivation for change and address ambivalence. Integrative coaching is helping patients make changes to lead healthier lives, address the gap between medical recommendations and the patient's success in implementing the recommendations. And then nursing coaching is aimed at working with individuals to promote maximum health potential by integrating skills of nursing and coaching, specifically integrated into what we do as APRN practice, because again, we take our nursing with us as we go, and critical component of this holistic care approach. In your reading, if you guys go to table 7.1 in that downloadable handout of the content of the book that I'm taking this from, it did talk about elements of guidance and coaching competencies. And on the left side there, it has guidance, and on the right side, it has coaching. And it said on the left, expert APRN has higher authority gradient is under guidance. And then when you move over to coaching, but the power is shared. Under guidance, the APRN is the expert, and under coaching, the patient is the expert and has the answers because you are taking what they want and what they're going to buy into. So I really like where they compared guidance and coaching and help you see that it's not exactly the same thing. Under guidance, it says telling, but under coaching, it says asking. So under guidance, it says teaching, and under coaching, it's inquiring. So those are some of those different components too when you're talking about the differences between guidance and coaching. But I think that's important because us as nurses, this is what I'm talking about with the nursing coaching, we kind of gradually understand this, I think. I feel like the nursing side of this allows us to blend guidance and coaching very well, where we know we can say these things, we can guide them and be expert counsel, but then when we consider holistically, we say, How does this sound like to you? Is this something that feels right to you? What are your thoughts and feelings on this? How can we incorporate this into what you're doing? So I do like that. The other part about the nursing coaching, obviously, is that as the APRN, right, it's integrated into what we do. In the book, it did talk about, there's been a lot of literature to say that coaching is a critical component of a holistic care approach for APRNs. In that reading, too, they also gave the example of the labor coach in midwifery as another example for that. If you had a chance to read that, it was pretty good. All right, talking about theories and research. Yay, let's talk a little bit about this here. There are lots of evidence-based theories and frameworks that are going to help inform you of what your guiding and coaching competency, should look like. Honestly, they are really deeply rooted in Florence Nightingale's environmental theory and the science of human caring, which broadens and deepens the therapeutic use of self. And the book says, in fact, the importance of the APRN patient therapeutic relationship is foundational to the APRN guidance and coaching competency. So although there are many theories and models, we will note that those that are important to informing and developing the APRN guidance and coaching competency are the ones we're going to talk about here. So Nightingale's environmental theory from 1860 makes a strong link between a person's environment and their health. So working with a person to manage their environment is the fundamental role of nursing. And as we experience a chronic illness epidemic in our modern times, this observation still holds true. External factors associated with patient surroundings greatly affect their lives, their development, and their biologic and physiologic processes. So back in 1860, Florence had this figured out, and this very much still holds true. And they say again in the book, this is seminal conceptual thinking lies at the heart of modern APRN guidance and coaching. And that is so very true. What you do, every interaction you have with the patient, whether it's acute care, primary care, inpatient, outpatient, what are we doing? At the heart of what we're doing is trying to guide and coach them to better health. Yes, they need to survive their acute illness that we encounter them in a lot of times. But if they do survive and they are getting better, there's times for teaching and educating. And that is very much when the guidance and coaching part comes into play. All right, this mid-range theory of integrative nurse coaching. This was developed in 2015. And this is an integrative nurse coaching framework that's a distinct nursing role that places clients and patients at the center and assists them in establishing health goals, creating change in lifestyle behaviors for health promotion and disease management, and implementing integrative modalities as appropriate. So the author identified 5 components to the model, and these are listed here: self-reflection, self-assessment, self-evaluation, self-care, integral perspectives and change, integrative lifestyle health and well-being, awareness and choice and listening with heart, which is healing, energy, awareness, resiliency, and transformation. And actually, based on this theoretical framework, this mid-range theory of integrative nurse coaching, the ANA, the American Nurse Association, actually published a guide to nurse coaching competencies, which is pretty neat. The other one they referred to was from 2002, which is the trans-theoretical model, which focuses on the integration of numerous psychotherapy and behavior change therapies. And the behavior change unfolds through a series of sequence stages of change. And the APRN can tailor the intervention to the patient's specific stage of change to maximize the chances that the patient will proceed through a needed change process. The trans-theoretical model has been used successfully with many of our other bad behaviors, such as alcohol and substance use, eating disorders, obesity, high-risk sexual behavior, and non-adherent medication use. And so they would argue that this model is highly relevant to the APRN because we can then tailor the intervention to their specific stage of change and tailor it to how or to meet the patient where they are. Watson's model of caring is based on loving kindness, which very much sounds nursing, but it's focused on the process of relating to others in a present way and going beyond the ego. So we're getting into a little bit of Freudian things here. This comes from 2011. And this is really focused on honoring and respecting the patient's values, histories, beliefs, goals as its foundation. And in your reading, it talked about this a little bit, and they talked about a little bit of some how it affects the APRN, and it talked about that a self-reflection for the APRN is needed to reach deep love and respect in a relationship. And this includes being present to and supportive of the expression of positive and negative feelings in your interaction with the patient. So that's kind of a different idea to use that self-reflection and truly having a love of the person, of the patient that you're working with. So then the book also goes into this positive psychology. It's a scientific study of the strengths that enable people to thrive. It makes a whole lot of sense that if we understand the psychology of what can help people thrive, we're going to be better guides and coaches, right? So the positive psychology field is founded on the belief that people want to lead meaningful and fulfilling lives, that they want to do what's best for them, and they want to enhance their own experiences along the way. A lot of psychologists bought into this idea, and those that worked in this kind of realm of the positive psychology created these 5 dimensions of well-being: positive emotion, engagement, relationship with others, meaning and purpose, achievement. So they said on there to see the 7.1 figure, which is great if you have that in your reading that you saw as well. So the positive emotions are emotions that feel good. So people who are flourishing feel positive emotions 3 to 1 higher than negative emotions, right? And they are deeper, full body feelings of connection to others, that they feel like they have meaning in their work. It's a very positive emotion. Engagement is also known as flow, in the state of being completely absorbed in an activity. It is the sweet spot between stress about it and being bored. So when you're riveted, when you're actively engaged, when it's really captivating your attention, it's not stressing you out, but it's not boring. People in this state are entirely absorbed in what they're doing, and they lose track of time while they're doing it. Perfect. Relationships are strong in people who are flourishing because other people matter, and very little in life is positive that is solitary. Meaning and purpose is evident in those who flourish because what they do and what they engage in matters to them, right? And they feel they're a part of something greater than themselves. People who are flourishing have a strong sense of achievement, that they've been practicing a craft, hobby, or their work for years, and they've finally achieved some level of mastery in what they do. So these dimensions of well-being lead people to have a positive mindset, is how I would say, and that's what achieves positive psychology. So the 5 dimensions of this are directly applicable to us as APRNs when we're interacting with a wide range of people. Down on figure 7.1 there in your reading, it shows the basic human needs: competence, autonomy, and relatedness as well. So let's kind of keep going through this, and that'll come back together. The growth mindset from 2017 from a lady by the last name of Dweck, and her study of mindset and its impact on achievement found that there are 2 types of belief systems. So one is a growth mindset, in which the individual believes they can learn and practice and achieve success. And then people with a fixed mindset their belief is that talents are fixed and effort cannot develop further talent. People with fixed mindsets de-link talent from effort, acting on the belief that talent's fixed. Fostering a growth mindset in the clinical space can create motivation and productivity, leading to improved outcomes. So guiding your patients to shift from a hunger for approval, which is this fixed mindset, to a passion for learning, which is the growth mindset, by the tiniest degree, she argued, can have a profound impact on nearly every aspect of life. So here, this is that 7.1. So the self-determination theory from 2006 is listed here on this screen. So this provides a framework for the understanding of human motivation. And the theory purports that there are two forms of motivation. We have internal and external, or intrinsic and extrinsic, right? And that all human beings are motivated both by rewards, which is outside of ourselves, and by our interests, our curiosities, and our values, which is the inside things, right? So this framework offers these conditions that are associated with the level of a person's motivation for engagement. And they feel that these three psychological needs, the competence, autonomy, and relatedness, have a robust impact on our wellness. So this would be directly applicable again to you as an APRN working within guidance and coaching, because you can promote the environment that supports competence, autonomy, and human relatedness, right? So when these three needs are satisfied, enhanced self-motivation and health follows. But when these are thwarted, the motivation and well-being are diminished. So when you recognize that the basic needs of your patient in front of you is that they're going to have a need to be feeling related, valued, wanted. So when you take that time to say, I'm here, I see you, I want to help you, that is part of that need for close, affectionate relationship. But you also know that they have the need for autonomy, to be in control of the course of their lives. We're saying, what is important to you as your goal, and how can I help you get that? And then competence need to be effective in our environment. They need to know, my argument would say, they need to know and be empowered that they do have choices here in their environment. In the reading to Exemplar 7.2 is a perfect example of how you could use APRN guidance and coaching competency in practice when they talk about this male who was 68 presented to the PCP with metabolic syndrome. And it walks you through, the powerful questions, an agenda setting, a guidance, awareness raising, that your challenge was offered, their accountability, the patient is in the action stage of change, and kind of goes down through that. So that's a really good one. I would encourage you to read it if you happen to skip right past that, because it really can maybe solidify for you guys in your mind of what it is we're talking about with guidance and coaching. All right, transitions in health and illness. So guidance and coaching assists patients with a variety of life experiences in order to reduce healthcare costs and improve your quality of care. So early work from even back to 1994 remains relevant today because APRN guidance and coaching competency and the contemporary interventions often delivered by you guys as APRNs is designed to ensure smooth transitions for the patients as they move across settings. So transition is a passage from one life phase, condition, or status to another. There's 4 types of transitions. We've got developmental, health and illness, situational, and organizational. So developmental reflect your life cycle transition, right? So we go from, infancy to toddlerhood to childhood to adolescence to parenthood. We age and death, right? Whereas health and illness transitions are adapting to illness, reducing the risk factors to prevent illness, or changing unhealthy lifestyles and behaviors. Situational transitions are most likely to include changes in your work or your family roles or your education. Organizational transitions are those that occur in the environment, so between agencies or in society, and they reflect the changes in structures and resources at a system level. Successful outcomes of your transitions, objective well-being, role mastery, and well-being of your relationships. So developmental, health and illness, and situational transitions are the most likely to lead to clinical encounters requiring guidance and coaching. The description of transitions as a focus for APRNs really helps underscore the need for and the importance of incorporating guidance and coaching into and being aware of and consciously choosing to do guidance and coaching in your interface with your therapeutic partnerships you're going to be developing with patients. So what are some of the skills? What are some of the things that you guys can use in your practice to build upon having good guidance and coaching impact for your patient, right? One of the things that I love that they said in this chapter was the effectiveness of guiding and coaching is based on the quality of your relationship between you and your patient. So we talk about this from nursing from day one, that trust is an essential component to building a relationship with somebody. So how do we build trust? Well, they talk about being present, communicating effectively, being non-judgmental, being empathetic, compassionate, managing conflict, and partnering with patients. So even though the competencies that we've talked about are part of the basic nursing care, what we're going to move into now is this discussion of skills within the context of an APRN doing it with guidance and coaching. Note that there's a considerable interaction amongst these skills we're going to talk about, and they are interdependent and should be part of everybody's toolbox moving forward. One of the hardest things for, I think, acute care in particular, is we are often meeting and interacting with patients in high stress, acute, we kind of get thrown into their life under a very highly stressful time. So I think about this even in my world as a hospitalist. Like I would walk into a room in a very busy ER and you're about to engage upon an interaction with a patient. They don't know you. You're not their primary care. They haven't known you for 10 years. You're a complete stranger and they're vulnerable. They're scared. Their family's scared and they feel awful, right? None of those factors are what we would choose, right, to say, oh, this is going to be a great start to really building a trusting relationship. It's challenging. And so how in the space of 10 minutes, 20 minutes, 30 minutes, can you engage with them in a way that does build this trust so that they can survive this acute illness and you can guide them as the expert giving this opinion. And then now throughout their stay with you or their time in the hospital, and maybe you care for them until discharge, right? And now you're really ready to get into more, you've done a lot of guidance, and now you're really ready to get into a lot of more coaching and empowerment. But again, it's building this idea of trust. They have to have trust in you and they have to believe that you care and you're doing this because you do truly care. So that you have to have that buy-in from them. So as an APRN, it is a lot more challenging, I have found, than when you have a 12-hour shift, maybe 2 or 3 shifts in a row with a patient, because you are really trying to accelerate this building of trust in a short amount of time. Okay? So also in the book, we go into a lot of these things on the screen here. I want to point out, they talk a lot about presence. And they even quote a Buddhist philosopher that said, the most precious gift we can give others is our presence, right? If we go back up to those previous screens, we just identified one of the 3 human basic needs is relatedness, or being needed to be in connection with other people. So when we give somebody the presence, our time, it is a very precious gift that we can give somebody. And that is true even in the relationship of nurse practitioner, CNS to patient. It's very true. So in guidance and coaching, though, it's not just a gift, but a prerequisite to being a full partner. So the ICF defined coaching presence as the ability to be fully conscious and create a spontaneous relationship with the patient, employing a style that is open, flexible, and confident. A definition of mindfulness then means to purposely pay attention in the present moment with a sense of acceptance and non-judgment. So presence requires mindfulness, and mindfulness requires presence. So I'm kind of going off on a soapbox here, you guys, but please really just stop whatever you're doing. If you're cooking dinner, if you're listening to this at all, if you've got 8 million things and it's 2 a.m, just stop for a second and let's really think about this for a minute. Okay. 2 common pitfalls to being present that will relate to you guys as an APRN, okay, are true things. And from today moving forward, from the day you listen to this moving forward, I want you to have this idea in the back of your mind and really be aware of it the next clinical and thereafter. Okay. External distractions and interruptions and the well-honed ability to anticipate what the patient needs are two pitfalls to being present. Okay. So think about this a second. And I'm telling you, please take this with a trust, if you will, from me and my experience. Pam Barthel will tell you the same thing. Your preceptors right now will tell you the same thing. Being mindful and being present are not the same thing. And in your practice as an APRN, no matter if you're in a huge 1,000-bed hospital, if you're in a rural clinic, if you're in an outpatient specialty, wherever you are, okay, being present and being mindful are not the same things. Because we are often physically present, but our mind is jumping from one thought to another. So when we're with our patient, our mind is not always mindfully aware of it, okay? I'm telling you, there's going to come a time when you are ready to walk into your first encounter with a patient, especially in the acute care realm or family practice, it doesn't matter. And in your mind, you have 8,000 things. And they could be things like, oh my gosh, I have 3 consults left and I'm supposed to be off in an hour and a half. I'm so behind. Oh my gosh, tonight is my night to pick up my daughter from soccer. And if I can't get there, I don't know who I would call because I'm so late. Oh my gosh, my headache has not gone away. I feel awful. Oh my gosh, I haven't had time for dinner or breakfast or lunch and I'm starving. Or, oh my gosh, I'm still furious at that interaction I had an hour ago that was so negative and I'm still really rattled. Or, oh my goodness, I'm so frustrated. I've asked for the blood sugar from 3 South for 20 minutes and I still don't have it. And I can't make a decision about what to do. And the families caught me in the hallway and they were yelling at me because no one's done anything about the blood sugar and blah, 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 right? All of these outside external distractions are going to be in your mind. And so your ability to then jump right into the patient and seeing them as a person and being mindful and present takes practice and skill. And so if you don't do that in that first interaction, you set yourself up for failures to be able to do guidance and coaching and even good care for the patient. So when we take the time to be aware of what we think during a patient visit, you could truly be astounded by how many thoughts unrelated to the patient enter our mind. Also, the book talks about this. We have deeply rooted ways of thinking as nurses and APRNs to anticipate patient problems. So we have been taught that we need to have answers for problems so we can fix a problem and thereby fix the patient. So we start to think way ahead, right? We start to anticipate. We think ahead of what we hear from the patient and we start anticipating. And when we do that, we have stopped being present. So we, as in us as APRNs, have to slow our thinking and follow what the patient is saying. And this is from your book. This is a fundamental challenge to the APRN. The art of coaching is to develop the ability to set aside distractions, including jumping ahead in problem solving, which often leads to misdiagnosis and care that is not patient-centered, and engage fully in the moment with the patient. Okay. You guys, this is really huge. And when we move out of this semester and you guys move into your next semester with Pam Barthel and you're getting into diagnosis and management, and we're really getting in now to actually acting as the APRN, where we're going to see the patient, come up with their diagnoses. You're going to have the mastery of all of your health assessment skills, and you're going to be into that next stage. This is pivotal. You need to start this now and practice this now. Okay. So presence, your ability to be there and be mindful. Here's some of the tips to do that. Okay. This was in the reading. Review the patient information before seeing the patient, not when you are initially with them. So allow and give yourself the 10, 15, 20 minutes or whatever to get all of that deep critically thinking done and have filtered through all of that information before you ever go in. Situate yourself at the eye level when possible to maximize eye contact. Okay. And I can tell you with this that they have done numerous studies over the last 20 years. And what they did was they would time how long a provider or a doctor went into the room. They would leave and they'd wait a couple minutes and they'd go in and they'd interview the patient and the family. And they would say, how long do you think they were in here? And they would gauge the perception of the patient and the family. And what they found was if the person sat down at eye level, they almost doubled the amount of time they were in there. But if they stood, they like halved the time. So what does that mean? If each person spent 10 minutes, but they walked in and they sat down, the perception of the patient would be he or she was in here for about 20 minutes. But if they stood the whole time, then they would say things like maybe 5-10 minutes, right? So that is a validated true fact that if you sit down and slow down, what you are portraying to the patient is, I am here for you. I am mindfully present. I am here, all of me. I'm listening to you. You are my focus, right? So sitting down is very important. Recognize the patient's feeling. Without this, your trust will be limited. So there are times when I walk in and I can tell they're really upset. They've waited 40 minutes, just to get checked in, then 4 hours in the ER, and you're just finally walking in there. And part of building that trust is to say, hey, I see you and I'm here for you, but I see you. So you can, or I can, maybe not as a student, you might not feel as comfortable, but as the APRN, when you walk in, you can say, I feel that you guys look really frustrated. I am so sorry that this has taken so long. I hate that this has taken this long. I know this is a really stressful time, right? So recognize how they're feeling. And if it's a negative thing, anger, frustration, one of those things, scared, acknowledge it. It helps build trust. If you are looking at or entering data into an device, invite the patient to look at the data with you. So if you have to do things on the computer, which I would encourage you not to do, but let's say you did, turn them and say, look, I have this screen of busy stuff, so I'm sorry, but while we talk, I'm going to get this done, and then I'll have, I'll get off this stupid thing and I'll, whatever. And then use the stop method to focus and be present. Stop what you're doing and pause. Take a breath. Anchor to the moment. Observe what is happening both outside and inside of yourself, and proceed. Continue doing what you were doing, using the information gained during this check-in, and change course. Then it talked a lot about communication. And I'm not going to get too much into that because we talk about communication quite a bit in other classes. However, part of communication is this here, which is listening, right? And the most basic and powerful way to connect with someone, to do that basic need of being related, is to listen. Just listen. Give your attention. Don't talk. Don't interrupt. Listening is a powerful foundational skill to guidance and coaching and any relationship, truly. But listening is the process of understanding others and establishing trust in the relationship. And trust is the foundation of your APRN and patient relationship. In your reading, they talked about the different levels of listening. Listening level 1 is tuned out, pretending, or ignoring. Level 2 was the selective listening with divided attention, and level 3 was attentive and empathetic listening. And obviously, it's more effective to be at level 3 listening, because empathetic listening is not only hearing what is said, but understanding the words and the emotions in the meeting. It's considered deep listening, and deep listening is hearing what is not said just as much as what has been said. So if you get to level 3 listening, as you saw in your reading, that is obviously going to be better as one of your guidance and coaching skills. So some of the skills, the tips and the tricks of listening is stop talking, relax for a minute, deep breathe, take a moment, review the record before you go in, remove distractions, listen for the tone of the conversation, acknowledge the feelings, and then ask powerful questions. Powerful questions listed in table 7.2 of your reading is really good. These are things like, what is the hardest part of all of this for you, right? Really trying to elicit and get to the heart of what's bothering them or how you could be effective, etc. Building strengths, help identify the patient's strengths, focus on what the patient does well, focus on what their positives are, right? That will help promote their confidence to achieve their goals. The classification of strengths and the 6 virtues are listed there, and I'm hoping you guys read all these too. Cultivate unconditional positive regard, accept the person for who they are without judgment, set boundaries by creating clarity of expectations as well. Cultivate a culture of empathy. Accurate empathy is being one with the patient in the here and now, highly sensitive to their experience in their world, and you will improve safety and outcomes. Creating a safe environment. They must feel physically and psychologically safe to engage in the relationship. Patients frequently feel they must please the provider or they may not receive good care, so we need to be aware of that and dissuade them from feeling that way. The actual physical space must be inviting and accepting environment. Sometimes that's completely out of our control, especially in the acute care setting. There's not much about being in the ICU room that feels really inviting, right? And again, the self-knowledge as an APRN, this gets again into what I was talking about with the presence. And then other tips and tricks to wind up the coaching. Asking for permission demonstrates to the patient that they have a choice and power in the relationship. I do palliative care, and this is very much something that I have found to be very positive in palliative care, is saying, is it okay with you if, or I'd like to do this if it's okay with you. I'd like to take the time to discuss blah, 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 blah. Because when they say yes, now we've kind of forged a couple inches ahead into our trust and our relationship, where I've acknowledged you have power here. You have the ability to say yay or nay. Let me know, what are you, yes or no kind of a thing. And if they tell me no, then I have to be prepared to not talk about what I really felt was important to talk about. Be curious, get to the feelings, and support the small changes, right? So if we're in the coaching role now, right? So we're doing what's important to them. We've already guided them with our expertise and our advice, and now we're getting into trying to get them to their goal. So we've identified what's important to them. And even if their goal is a big thing down the road, the small changes have to be acknowledged and supported and celebrated, right? The APRN coaching process stages of change, and I hope you guys saw these as well in your reading, that guidance and coaching are the basis for promoting the change, and that trans-theoretical model of change that we already talked about includes assessing the readiness of the patient then to engage in their change, and then prepare to make it, etc. So this pre-contemplation is the kind of like, I'm not so sure, right? So it's a little bit of resistance. We make them feel understood, right? The next step is contemplation. Well, they're kind of ambivalent, but they're talking about it. There's kind of a positive, negative vibe going on, but they're considering. The preparation is when they say vroom, vroom, right? Which is now we're good to go. We've removed the barriers. We're making the plan. We're getting ready to launch. And then action is roar, where we're actually full speed ahead. And then maintenance is, kind of coasting and doing it and staying true to the course. Patient readiness, is so hard when you're like, just say yes. But if the APRN is considering using coaching, the patients must first be deemed well enough to imagine a better future for themselves. So Coaching would not be productive with people who are so sick or they're not ready or they can't envision a different future. So if they're mentally ill, if they're severely depressed, if they're inebriated, if they have too much dementia or they're in such a acute traumatic state or so acutely ill that they couldn't form a coaching partnership. So we have to assess their readiness, right? Resistance, yeah, that's that tough part. The main task, though, for you as the APRN is that you have to help them feel understood. You're not going to overcome that resistance without it. The example in the book said, you could make a statement such as, I can see how smoking makes you feel like you are making your own decisions in your life, and that's important to you. But if you ever want to quit, come back and I will work with you and we can get there, right? Motivational interviewing is a way of communicating with patients to help get them past their resistance and their ambivalence and moving forward with change. And they gave an example of that in the exemplar 7.4. Okay, wrapping it up, let's talk quickly about the 4 A's of the coaching process, okay? And this is agenda setting. This is where you hand over control and choice of topic to the patient. You want to have specific, measurable, and have things that are within the patient's control. And the agenda must be determined for coaching to occur. You have to know what you have to have a mutual decision of what you're going to be coaching on. So your skill is to excavate what is the most meaningful and clarify their needs. And you can use some powerful questions. You could say, what is the most important or helpful thing to you at this time? What is going to give you the most bang for your buck? What is most important to you? Then you move on to awareness raising, challenging the patient's mindset about the issue, asking powerful questions that require deep reflection. And then you should develop 5 powerful questions to use regularly. The ones they talked about in your reading were, what is working well? Who do you need to become to make it happen? What do you want to see happen? What do you want to be held accountable for? What do you most value about yourself? And what would your life be like if you were not X, Y, and Z? Depressed, overweight, whatever. And what is your deepest desire for yourself? So we had agenda, awareness, then we get to actions and goal setting. So linked raised awareness to the goals, brainstorm and determine and challenge whether the person could do more gently, right? But you're brainstorming to come up with a list of ideas and solutions to which the patient can agree, reject, or modify, okay? You can say things like, on a scale of 1 to 10, how successful do you think you would be if we did whatever? What would you think could get in your way? What's an obstacle and how could we get that? And I would challenge you to, right now you're drinking 10 Mountain Dews a day and you said, well, you'll cut it down to 8, but I'm challenging you to go to 5. I really feel like you could do that. And let's kind of do something really meaningful. Let's get down to 5, just as an example. So you're setting your actions. And then the accountability is helping the person set those boundaries and guidelines. So using their own resources to achieve accountability and outline the plan for what happens if your goals are not being met. So what will you do if you get off plan? What is your when-then plan, etc. So the 4 A's are the agenda, awareness, action, and accountability. Okay, so to build coaching into practice, those are listed here. We talked about creating the safe and welcoming environment, using your resources, etc. So, in conclusion, guidance and coaching are necessary. It's also effective and critical that you develop these skills that you can bring to your patient interactions. Guidance is directive and values the patient's education, and coaching is focused on the goals established by the patient. So I do think that this competency is something that we don't always talk enough about or spend enough time giving you guys the education about. I know this was a fast and quick hour-long discussion on it. I wish we had 6 hours to dive into this greatly because the psychology of it and the understanding of it is really important because of what it takes to really understand patients and your guys' relationship with them so that you can be impactful and get to the best outcomes that you want. Remember that you can ask a lot of questions, ask permission, build on their strengths, support their small changes. Don't be afraid to be curious. Don't be afraid to challenge them, and don't be afraid to get to feelings for your patient. All right. Thank you for hanging in there. Please, of course, email me, call me, anything if you have any questions or concerns. I know this was very fast. I would encourage you guys, if you're those kind of students, to print off this chapter that we read about today and put it away somewhere for you to have to refer back to, because this is a lot of great information. We went through it very quickly. But this really is a skill, you guys, that if you really spend some time reflecting upon this and integrating it into your practice, will be a huge tool for you. And I would even challenge you, if you have any clinicals left, to kind of think about this even in your interactions already in health assessment, and definitely in your interactions when you move forward into diagnosis and management. Okay, see you next week. Bye-bye.